So we are live.
Okay, good. Tell me when to start. Should I share my screen or wait for some time?
Okay, sir.
Shuk, should I
Yes,
start
sir.
sharing?
Yes.
Okay. Okay, so good afternoon, everybody. Today we're going to discuss an important topic, especially in our country, where we have to deal with fracture neck femurs who have either not been treated at all or have failed the initial treatment. Okay, so because as you all know, the fracture neck femur, especially in the young adults, is a challenging problem. Interestingly, if you look at the world literature, the incidence under the age of 50 years is somewhere around 3%. But I think in our country, it's probably much more common. And if we look at our own series over the last many years, last 20 years, of more than, I think, about 1,500 cases, nearly 25 to 30% are less than 50 years. So we haven't really tried to make an accurate analysis of these, but it's much higher than 3% for sure. Okay. This is a challenge which we are going to be continuing to face, and late presentations are still a reality, and they can be even more challenging. And if we look at the literature for it is sparse, and there really is no controlled trial of different methods, because if you look at any person doing a large number of these cases, they usually have one method they prefer. So it's difficult to try to do a sort of a controlled trial or a randomized trial on this. But you have to go by experience of various authors on it. Okay. Now, Professor Sandhu from Amritsar, who has a huge experience of these, came out with a classification of these neglected fractures, which is a useful, practical classification, which is based on basically the size of the head fragment, the gap, and if there were signs of AVN. Okay, now sometimes just looking at these x-rays is difficult, especially for the patients who have not been treated. It's difficult to make out the signs of AVN because when the fracture is not united or it's not fixed, you don't see the classical collapse that you see with AVN in a fracture that is fixed or is sort of united. Okay, so it's a little more difficult, and you may have to do either a bone scan or a MRI to really look at the vascularity of the head, depending on whether it's going to change your management or not. Okay, so if you look at the ways of dealing with it, you have methods which we try to preserve the head. And obviously this starts with internal fixation. The other most popular method of treating with these late presentations and non-unions is the valgus osteotomy with internal fixation. The free fibula graft is quite popular in certain centers in our country. The vascularized fibula graft is another interesting way of treating these, but has not gained popularity because probably to try and put in the fibula and maintain the vascularity isn't that easy. You can use other forms of vascularized graft as well. You can use the muscle-based pedicle bone grafts, which is popularized again in the eastern region by Professor Bakshi. And of course, you have the old methods like McMurray's osteotomy or McMurray's osteotomy with some form of fixation. Okay, so now I think by and large, world over, the valgus osteotomy seems to be the most popular way of dealing with these problems. And interestingly, it's based on a very old concept by Powell, which was based on the fact that depending on the angle of the fracture and the shear angle, the forces that gravity can create either a shear at the fracture if the fracture line is vertical, or compression at the fracture if the fracture line is more horizontal. So you need to try and calculate the shear angle. And if you look at the resultant forces, you have to minus 25 degrees from it, because if your angle is 25 to 30 degrees, the forces acting on the fracture are more or less all compressive and very little of shear forces on it. So the idea is to try and reduce the shear angle to around 25 to 30 degrees, and your osteotomy would be the difference between the shear angle and what you want as your eventual angle, which will be around 25 to 30 degrees. Okay, now you can use various methods. The angled blade plate is the one that is again very popular. The other method is the DHS kind of implant, where you can compress across the fracture with your lag screw. Okay, so the idea is that you insert the blade at an angle to the neck, which once you do your osteotomy will convert the fracture angle to around 25 degrees. So if your initial shear angle is close to 90 or 85 degrees, you have to take a large, and you want to get it down to 25 degrees. So you need to correct it to 25 degrees. So your osteotomy will need to be an angle of 45 degrees, 50 degrees to get it down to 25, fracture angle of 25 degrees. Okay, now when you're doing this, especially with the angled plate, the idea is to do your osteotomy, but don't complete it, because you want a stable part to put in this, to do your chiseling and then put in your blade. And then once you put in the blade, you complete the last part of the osteotomy and then close the gap and fix the osteotomy. Now, interestingly, the way you fix this osteotomy is also important, because if you put a sort of unicortical screw in the last hole and then put in your first plate hole screw, as you tighten this screw, this will draw this fragment against this upper fragment and cause a kind of offset compression. The term used here is offset compression, because this part is medialized initially, and as you tighten this screw, it's going to draw it laterally, and because of this angle of the osteotomy, is going to compress it against the proximal fragment. And then you put in your other screws so that you get a nice stable fixation. The other ways is to actually use a compression device to get more compression if you think that is required. Okay, so that would be the simple surgical steps. Of course, you need to calculate your angles and make sure you get the correct wedge to get this angle right. And this is, again, as I mentioned, based on Powell's concept that and the effects of mechanical stress on healing, which show that pure compression encourages callus. Tensile stresses retard the process, while shearing stresses are the most harmful and will damage whatever scaffolding to heal the fracture. So good results with this method of osteotomy have been reported by Marty et al. In JBJS 1989, and again from India by Magu et al. In CORR 2009. Now, as I mentioned, you can do this with the DHS. So here's a patient who presented to us 6 months after the initial fixation. You can see how the screws have drifted out, and this fracture has gone on to varus. And here what you would do is, again, instead of blade plate, use a DHS. You get your angle right, you do your osteotomy, and you convert this to around a 25 to 30 degree angle, so that the shear forces are converted to compressive forces, and that will allow the fracture to go on to heal. And this is a follow-up at 16 months after the injury, and this went on to do well. The angle blade plate is the other method. This is more of a basal than a true cervical neck fracture, but again, you can see has failed with the DHS. So here's your osteotomy. And today, the idea is also to try and lateralize your distal fragment, because this is important to try and get your mechanical axis right. Otherwise, you get a stress on the knee, which can be a problem later. So the idea is to try and lateralize it, and you can do that by leaving your plate out a bit. As you tighten your screws, as mentioned earlier, this is going to pull this fragment more laterally and cause offset compression. And the wedge that you have, you can use to fill in here so that you get a nice, good healing of the osteotomy. Again, this is at follow-up at 3 months. You can see how beautifully that's gone on to heal. And this is again at 9 months, shows a good healing of the osteotomy as well as of the fracture. Another situation where initially this patient had a McMurray's osteotomy. If you look at the head, there are some signs of AVN, but if in a young patient, even with some signs of AVN, as long as there's no complete collapse of the head, you will still try to unite the fracture. Again, your planning, your angle that you will put your sort of chisel blade in so that you get your plate blade in the right angle, and then you do your complete your osteotomy, do your osteotomy, converting the very vertical fracture. If you go back and look at the original X-ray, you can see it's almost a vertical fracture line, and here it's converted to a reasonably good angle where the forces can work as a compression force, and you can see how this has gone on to heal nicely. And again, after implant removal, continues to do well. 4 years post the osteotomy without any major difficulty or morbidity. So sometimes you can combine your osteotomy with bone graft. Now, if you see a case like this where the neck is completely absorbed, you could either use a fibula along with an osteotomy with a blade plate. If you're doing a DHS, it becomes difficult to get place to put in a fibula as well as a DHS plate. And here, sometimes we would use bone graft through the DHS reamed hole. Okay, so you put in lots of bone graft here, then put in your screw. Again, you've completed your osteotomy. You can add a second lag screw. And this is again showing how the fractures gone on to heal. Of course, you need to see long-term follow-ups to see that they do not have AVN. Now, one of the problems with doing the osteotomy is that occasionally you can get troublesome lengthening, and therefore it's important that you've got a decent range of adduction before you do your osteotomy. The patient does not have good adduction and you do an osteotomy, you will end up valgusizing the entire hip. And this is what happened with this patient. Even although he's fracture united, even 1.5 years post-op, you can see he's got this lengthening which bothers him, and the whole pelvis is tilted when he walks because of that. So I think this is something that you should be careful about, is to make sure that you check that he's got a decent range of varus, can get the hip adducted adequately. Sorry, not range of varus, but adduction before you do a valgus osteotomy in these hips. The other interesting thing is that Powell actually described 2 types of osteotomy, okay? Reorientation by the wedge osteotomy, which we've seen earlier. He also described a reorienting Y osteotomy, okay? Now, this is the wedge osteotomy. You can see when you do the wedge, you have a good contact here because the neck is not absorbed, and this will convert the shear forces to compressive forces. But if the neck is totally absorbed, as you see in this situation, and you do the same osteotomy, you're still going to get shear forces in this area. You may have compressive forces here, but the majority of the head will still be in getting the shear forces, resulting in failure of your fixation. So he described this reorienting Y osteotomy, where you took a slightly different wedge. So your wedge direction was across here and then about halfway across here. And then when you medialize this sort of distal fragment under the head. Okay, now we don't have the ideal implant for this. So this is something we could look at as to when we're doing this for the neck, when it's resorbed completely, the Y osteotomy is a useful way of dealing with it. And this is a patient we had to deal with some time ago. So here's what we did. We did this. You can see how we've translated the distal fragment medially so that it supports the head. Okay, and he did quite well. Unfortunately, he did develop AVN and then that head collapsed. And so we had to take out, we haven't yet done a total hip, is managing, but this is something with AVN, he developed a problem, but you can see how it was going on to heal quite well, and he had a good function before this problem happened. He was managing quite well for about 2 years. Then he developed collapse, and sort of the implant started penetrating the joint and we had to remove it. Okay, now there's some modifications. You have the Dixon's osteotomy where you rotate it also, and that can reduce the amount of wedge you need to take. And also Dr. Sen from Chandigarh described the osteotomy, which was more basal rather than a subtrochanteric osteotomy, a basal neck osteotomy, which then again realigned the neck in a reasonable position to get a varus, to get the shear forces neutralized, and he's reported good results with that. However, that is not a method that has gained so much popularity. So the other most popular method in India is the fibula graft and the free fibula graft. And people use it as a single graft. Some use it as a double graft. So you can use either with screws or without screws. Most people would use a single fibula graft with 2 screws where it's possible. And Professor Nagi reported on 52 cases, of which 40 were available for follow-up. So we lost 12 and 38 of these united. 14 of these had AVN, but only 5 had very severe collapse, which disabled them. So here's an example. This is a 46-year-old with a 10-month-old neck femur. And here we use this 2 cannulated screws and a fibula graft. And this is how it went on to heal. This is a 2-year, 8-month follow-up. It's gone on to heal well with very good functional results. But again, you still may have the problems of AVN and collapse if that happens. So that's something that you have to keep in mind. So in a older patient, maybe worth getting a bone scan to rule out, or a MRI to rule out AVN before you do any of these methods. I think in a younger patient, you're still going to try to salvage the hip joint rather than do a arthroplasty. Now, there are some complications of the fibula graft. Of course, you can, like I mentioned, AVN. If you have AVN, even with the fibula graft, the chances of collapse are high. You have to be careful of this stress fracture. So like, especially if you have the fibula graft and the screw hole very close to each other, you have quite a big hole here. And that could be a stress riser to cause stress fracture there. And this is what happened in this patient. Then we had to fix it with a plate and get it to heal. And you can also have, where your fixation is not adequate, fracture of the fibula graft, especially if you have a big shear angle, the stresses are quite high. So I think you need to try and neutralize the shear angle by converting it to a more horizontal fracture line, even when you use the fibula graft in some of these patients. Now, the muscle pedicle bone graft, originally reported by Myers from the posterior side, using the quadratus femoris, somehow did not gain popularity. Professor Bakshi from Kolkata has reported on 56 patients with non-unions in JBJS 1986, treated with either quadratus femoris or gluteus medius muscle pedicle bone graft. My own experience with this for neck femur is limited. We don't use it. So I can't comment on my own experience with it, but certainly seems to be popular again among some surgeons, but not widely popular across the country. And as I mentioned, this vascularized fibula graft, Lacroix et al. Reported on 22 patients with non-union under the age of 50, 20 achieved union. But even in this group, 13 showed signs of radiological, signs of AVN, okay? So that's another thing you need to watch out. Just because you use a vascularized fibula doesn't mean that you will not get AVN or collapse with AVN. Now, just to mention McMurray's osteotomy, this was a method which was still being used quite a lot until fairly recently in some parts of the country. It's a method which you probably still have to have an idea for your MS and DNB exams. At least you should know what it is. And this was sort of a method designed by McMurray, originally used for treating osteoarthritis of the hip, interestingly. But you did an osteotomy in the subtrochanteric region and you medialized the distal fragment to support the fracture. Initially, you kept it in wide abduction and then you straightened it out so that you got a union of the fracture. Now, we used this till some years ago, and it's still there in the back of my mind in some cases where I think other methods are likely to fail. Like this is a 22-year-old where we actually put in this screw. You can see the huge gap there. And then we did this McMurray osteotomy underneath it, and you can see how beautifully this is healed. In principle, if you look at it, it's kind of worked a bit like the Y osteotomy of bowels, except that we were not fixing this. If we had some method of fixing this nicely, it would be like a Y osteotomy with this neck part supporting this distal part supporting the neck and allowing it to heal adequately. And this is a 17-month post-op, and she did really well. So this is something, again, to have in the back of your mind in some difficult cases, although it does mean keeping the patient in a spica for some time, which is something that is not so well tolerated today. Okay, now, so as I mentioned, then all the other problem that the McMurray's osteotomy will make it a little more difficult to do your subsequent THR. Okay. So I think all these methods, which we discussed, all work, but none of them works all the time. All have some significant failure rate. So you really need to find out what works well with you, develop a technique for doing that well, and hopefully you'll be able to get good results in close to at least 70 to 80% of your patients. Now, what about salvage? When you know that you can't actually really save the head, then you have certain options. One is an excision arthroplasty, like a girdle stone. And interestingly, this is something which we use only if there's infection, and some patients do reasonably well. You have the pelvic support osteotomy. This is again a method where the head is beyond salvage in the younger patient, is worth trying. Arthrodesis in the neck femur is something that doesn't work so well, okay, because if you have AVN, then that part of the head is difficult to heal. Okay, so here's a patient. This was a 50-year-old, but he developed severe infection, and we ended up excising everything with the idea that later on do a total hip. But he was so happy with it and was managing okay that he decided he didn't need further surgery. But it varies. So if you go back into history, patients with tuberculosis hip did quite well with the girdle stone arthroplasty because they developed some kind of fibrosis which allowed stability, and because of the pseudarthrosis there, you had a reasonable range of motion. So depending on the amount of fibrosis you develop around that girdle stone, some patients can manage quite well, but others find it very difficult to do the activities of daily living, and you then have to do some kind of arthroplasty. Now, the pelvic support osteotomy is another way where you can sort of help some patients, like this lady who had this sort of McMurray osteotomy. You can see the head is completely gone. It's there, but it's completely gone. So here what we decided to do was to do this pelvic support osteotomy where the head, sort of the limb was supported on this area against the ischium and this area, and she did quite well. She was able to cycle, walk around without support. And so this is again an option that you can think of. Again, the results are not always predictable. You can use the Ilizarov method where you can do your osteotomy and lengthening with varicization of the distal part. So you do quite a severe osteotomy on sort of angulation here of almost 60 degrees below the level of the ischial tuberosity, and lower down you need to parasize it, and you can lengthen from there to restore length. And when you do this, you are able to restore the mechanical axis reasonably well, because otherwise you have this problem with the mechanical axis at the knee, which in the long term will cause problems with the knee joint. So these are all the methods of dealing with neck femur without resorting to a total hip replacement or a prosthetic replacement. And I think in the younger patient, try to do whatever you can do to avoid these. Of course, in the older patient, you have the option of a hemiarthroplasty or a total hip replacement. And in some younger patients where the joint has completely gone, you have no option. So here's a 45-year-old lady with a neck femur fracture, and unfortunately was treated with screws which penetrated the joint. They were not the right screws. The reduction wasn't adequate. And by the time she came to us, almost 2.5 years after the fixation, she had this situation with very osteoporotic bone. So we were really scared about causing a fracture. So we actually did a trochanteric osteotomy at a total hip replacement. And she's done really well. She recently came back, and so that's almost a 15-year follow-up, and she's still doing well with this hip replacement. As I showed the earlier case, which had avian after fibular graft, again, we converted that to a hybrid hip replacement, and she did well. If you have a failed hemiarthroplasty, done for a youngish patient here, but in the older patient, then a total hip replacement is the answer, because they can get back a useful function, get back their hip dynamics and the length as well. And failed McMurray's can sometimes make it difficult to do a arthroplasty, and here you may have to osteotomize the trochanter, do your total hip replacement, and get the correct alignment, and do a good wiring of the trochanter so that you get a good stable trochanter, and these will do quite well as well. So I think these fracture neck femurs need to be assessed very carefully. You need to look at the head to see if it is salvageable. You need to look at the joint to see that it's not already arthritic or damaged, and then try to see what is your best option. Okay, try to, especially in the younger patient, use methods where you can conserve the hip joint. And I think with our osteotomies and fibular graft, etc., we've got good methods to try and salvage the hip without resorting to an arthroplasty. But in the older patient, it may be easier to do an arthroplasty, and where the hip is already beyond salvage, you have to think of the arthroplasty as one of the options in your treatment. Okay, so I think try to salvage the head where possible, but if the joint replacement is still a valid option where salvage is not possible, and definitely so in the older patient. Thank you. Okay, so I'm going to stop sharing my screen and take questions from anybody. Yeah. Okay. So Janki?
Yes, sir.
Yeah, so you can get the question and answer session going.
Okay, sir. Sir, one thing which I want to ask, sir, because most of us do not have that experience of using the blade plate. So how did you prepare the slot of blade plate, sir, after the osteotomy?
No. So you first prepare the slot, okay?
How to prepare that one, sir?
So if you look at the blade plate, it has a chisel, okay? Yes. Which is designed in the same way that the blade will fit in exactly into that hole, okay? So the advantage of this is that it takes away very little bone. If you look at the cross section, you're actually not removing any bone, unlike the DHS, okay, where you take out a core of bone. Okay, so this is, today with the newer instrumentation, you also have a cannulated guide. So there's a guide wire which you can put the chisel over and then make your slot. Okay, so that makes life a bit easier. The lateral cortex has to be drilled so that you don't have to use a lot of force in introducing the chisel into the bone. Okay. And then you have to go slowly. So you don't try to hammer it in all the way because your chisel will get stuck. So do a bit, pull it out, do a bit more, pull it out. Because if you're doing it in good quality bone, and in the younger patients, the bone quality can be quite good. Suddenly you'll find you can't pull your chisel out again. So do a little bit, back it out, do a little bit, back it out. Do your osteotomy, but don't complete it. Okay. So the last bit on the medial side, you leave till once you've done your chisel, you put in your blade and then use the blade to more or less break it, or just use an osteotome to cut the final bit. And then as you bring the limb to the plate, you're going to close the wedge. Okay. So you have to use this. Okay. And otherwise use a DHS if you don't have the blade plate. And I think the blade plate is technically a little demanding because you have to get all three planes right. Okay. So you got to get the varus valgus angle right, but you also need to get the orientation of the plate right in both sides. So if it's a little bit tilted this way, your plate's going to go back. It's a little bit tilted that way, your plate's going to go in the front. Okay. So you need to get the tilt of the plate, the angle, everything right so that your plate sits on the bone once you've closed your wedge after the osteotomy. So technically a little more difficult. With the DHS, makes life a lot easier, but then you are taking out bone when you make your drill. The advantage is you can compress across the fracture if the head size is reasonable. If the head size is small, I think the threads in the lag screw and the DHS are a bit long. So if you have special lag screws with shorter threads, it may be a useful thing to have in the fracture neck femur. Okay.
And sir, if at first time we are able to, we are not able to put it correctly, do you have freedom to revise it during the blade plate?
The angle blade plate. So
Yes,
this
sir.
is the problem. Once you make your chisel cut, it becomes very difficult to change it. So either you can go at a different level. Okay. If you have room, you can go a little higher and do the osteotomy, but doing it at the same level becomes almost impossible because the blade and the chisel will again go exactly in the same track. Okay, so it becomes very difficult to change that angle or rotation once you've made your sort of hole for or your track for the blade. Okay, so you have to get it right from the beginning. So keep checking. Okay, again, the instrumentation has a side sort of attachment to it, which will show that it's aligned with the shaft. Okay, so every time you're tapping, just check that you're not angulating your chisel in either anteriorly or posteriorly to cause problems. Okay.
Sir, while you are fixing the screw, uh, how you decide that you should fix it with CCS or with the DHS?
So that is, so I think if you have got good enough bone, I mean like, so a decent quality bone, okay, I would go for the angle blade plate, yeah. Now, or even in poor quality bone, as long as you've got enough bone. Okay, where you have a very small bit of bone, then it becomes difficult because when you're hammering the last bit, you might displace that. Okay, so then you put in wires, etc. Now, I mean, I'm not sure it matters too much which method you use. I think you can get reasonably good results with the DHS as well. But certainly in the patient where the bone quality is poor, I would prefer the angle blade plate. Okay. So where the good quality bone is good and the DHS will hold well, you can use the DHS. But if you're worried about the quality of bone, but the size is good enough, then an angle blade plate has an advantage of getting you very good hold even in osteoporotic bone. Okay. You have one option today, which is the LCP DHS, which has a helical blade. Okay, so now that is a method which is actually probably the best, I mean, the easiest, at least in my hands, as long as again the head fragment is of a reasonable size, because the portion of the helical blade is slightly long. Okay, so that is a big advantage, because you can actually rotate your plate even after you put in your helical blade. So it actually is probably technically the easiest thing to do in terms of seating your plate right. Okay, so I haven't talked about it, but today that is available in our armamentarium, which is the LCP DHS with the helical blade, not the screw, but the helical blade. We also have it with the screw, but you have the helical blade where you can, even after you put the barrel into the plate, you can rotate the plate without rotating the screw or the helical blade.
And that preserves the bone also, sir.
Yeah, and that also preserves the bone. So that's not something I mentioned in the talk, but that's something we use quite commonly today.
Okay, sir. So that I find you using more in elderly patients. For the young also, we can use that one, sir?
Yeah, you can use it, but again, so if the bone quality is very good, you have to make sure you drill adequately so that this helical blade doesn't get stuck. Okay.
And during primary fixation, sir, sometimes you use the inverted angle configuration of CC screw, and sometimes you use diamond shape. So
Yeah. Okay.
how to
So
decide that one?
I think this is something which is going to change in the near future. Okay, because I don't think cannulated screws in itself are a very good fixation option for neck femur fractures. Okay, because it allows toggling and it's not angle stable. So I think with the newer generation implants coming, you should be able to compress the fracture, at the same time fix it with some kind of angle stable implant, which doesn't allow toggling at the fracture and varus collapse of the neck. Okay, so I think just cannulated screws, parallel cannulated screws are not the ideal way of treating them. Today you have other sort of configurations of screws where you can use, one is the BDSF, where you use the diver, where you have one screw going at a different angle, okay, bidirectional stable fixation. You also have the Powell screw, where you put a third screw at a different direction. You also convert screws after the initial compression to fully threaded screws so that they don't allow as much collapse. Because one of the problems with the fractured neck femur in the initial fixation is with the parallel screws, sometimes they heal, but gradually the neck keeps collapsing till you end up quite a lot of shortening. And that in a young patient can be quite a significant disability. Okay, so I think we've seen some of these patients gradually collapse over 3 to 6 months before they finally heal. And by that time, they're almost a centimeter or too short, which in a young patient is quite a disability. Okay.
In revision cases, sir, I have seen you are using that sometimes a distal femoral locking compression plate, or the DCP. I do not have idea, sir.
That's not for neck fractures. That's more for trochanteric and subtrochanteric fractures, not for neck fractures. Okay.
So, and sir, what is for the initial surgery? How much
So
important is
what
the
about,
time?
I think you should try and get questions from the DNB, and then you can ask your questions later, Janki.
Yes, sir.
Hello, sir. Good evening, sir.
Yeah.
And sir,
Monopolizing
just like,
the questions. Okay.
सर जैसे DHS और DHS हम लोग करते हैं, उसमें हेड का आइडियल पोजीशन हम लोग लेते हैं इम्प्लांट का, तो वैसा कोई इम्प्लांट पोजीशन का आइडियल पोजीशन इसमें होता है क्या सर, रिवीजन या नेग्लेक्टेड फिक्सेशन जब हम करते हैं उस टाइम में?
So you are still aiming for the same point, okay? Which is
Okay,
to
sir.
get a TAD of less than 20.
25. Yes, sir.
20, 25, in the even more, even less so in this. Okay. Now,
Okay.
to some extent, you may be governed by what has been there before. Okay. So if you have a void more anteriorly, you may have to go a little more posteriorly, or if you have the void more posteriorly, you may have to go a little more anteriorly. But the idea is to get into bone close to the subchondral bone so that you get a good hold of the DHS screw. Otherwise, you're going to get failure again, because even more so than in the primary fixation, you need good hold of the proximal fragment, otherwise it's
Yes.
going to fail.
And so, what is the best implant with the fibula?
So with the fibula, I think the angle blade plate or just cannulated screws. Okay. So if you're
If
doing an
we are
osteotomy with it, then use the angle blade plate. If you think just screws are enough, then you can use screws. Okay.
2 screws, sir.
At least I think, yeah, if not more. Sometimes you get in 3 if you have the room for it.
And the position of that the screws, sir. One superior, one
So
inferior.
we've been, yeah, I mean, no, ideally, there's no real evidence to show one is better than the other.
Yes, sir.
But that's what we normally aim for, is to put the fibula central and a screw below and above. Okay.
Okay.
But
Okay.
there is no, this is not based on any evidence.
And sir, any role of fracture healing augmentation in is like we use for other.
So bone grafting is a possibility. Yeah.
Yes.
So like I said, some cases where there's a lot of bone loss, you can fill in bone graft through the DHS barrel hole.
Yes, sir.
Okay.
Yes, sir.
So that's one option. We don't use things like BMP, etc. But fibula graft is again a augmentation as well, because although it gives mechanical stability, we also believe it has some biological property as well. Yeah? Because you're putting it with immediately as you cut it, you put it in. Yeah? So it's still, although it's cortical bone, it still has some biological function, because if you look at some of the old x-rays over a period of time, it
Yes.
gradually gets absorbed. Yeah. Although some people will refute this, but we've certainly seen cases where it's got absorbed over a period of time.
And sir, if we are doing fibula with the 2 screw or angle blade plate, then what is the ideal time to removal of implant, or they do not required to be removed?
So I think in a young patient, it's generally preferred to remove the implant. Okay. What
At
you
what
have to
time?
be sure. So yeah, you have to be sure the fracture is healed. Okay. And
Yes,
that
sir.
would mean that usually at least 1.5 to 2 years. Yeah.
Okay, yes, sir. Thank you, sir.
So any other questions?
Yes, sir. Sir, one question usually asked during the exam, in young patient, what you prefer, hemiarthroplasty or total, if for the revision, if it is needed?
So I think basically, I think if you're doing it for a failed neck femur, it's usually a total hip replacement, yeah? Unless there's a medical contraindication for it. Huh? I mean, the patient may not, if the acetabulum is good and the patient may be a high-risk patient where you don't want to do more extensive surgery. Otherwise, it's almost always a total hip rather than a hemi. Yeah?
What is the reason for that, sir?
Because if you look at long-term results and functional results of total hip, they are better than that of a hemi. Simple, huh? So even in a fresh case in the younger neck femur, that means in the 60, 65, in a physiologically fit patient, many people would argue that you should do a primary total hip rather than a hemi. Because in terms of revision rates, function, etc., it's better. However, the dislocation rates may be a little higher in a fresh fracture. Okay, but in the old cases, by then you have enough fibrosis that you should not have higher dislocation rate. So and usually the acetabulum has become soft, etc. So it doesn't make sense to do a hemiarthroplasty. Okay? And if the acetabulum is already damaged, then you have no choice anyway. The screws have gone into the hip joint and damaged the hip joint. Then anyway, you have to do a total hip replacement. Okay?
And this one, sir, it is considered as surgical emergency. So when to fix, sir, means for the time duration, because it is
Okay,
very
so I think again, so this is like open fractures. Okay, people would say you have to do it within 6 hours. I think today that concept has changed somewhat because I think it's more important to have the right team there rather than to do it in the middle of the night without the proper team. Yeah. So you want you want a surgeon with some experience, you want anesthetists who are qualified to deal with it, you want your staff who can give you the correct instrument, you want the image intensifier guy who can give you a decent image. Okay. So I think you would do it as soon as practical in a regular list. So if it comes at 9 o'clock at night, instead of doing at 12 o'clock at night, it would make sense to do it first case in the morning. Okay. On your regular list. Now, practically, this may not always be possible, but that is what would be the best option for the patient. Okay. Of course, if he's diabetic, etc., you need to get that corrected as much as at least reasonably corrected. You don't want a patient with ketoacidosis going into surgery. Okay. In the older patient, of course, there are other medical comorbidities that you may have to deal with. But in young patients, those are not such a big deal. Okay. But the idea would be to get it done as soon as possible, but in the right circumstances. Okay. Now, if you have an experienced team ready to do it at 12 o'clock at night, so do it as soon as possible. But that is very rare in our situation where you have all the right people there in the middle of the night. Okay.
Sir, upper limit of age for fixation, sir.
So there's no upper limit as such. Okay. Now, for the undisplaced fracture, there's no limit. Okay. So even if it's an 80-year-old with a undisplaced fracture neck femur, you would fix it rather than replace it. But above 65 in the Western population, and in India, probably in the ladies, maybe even 60, maybe even 55, depending on the nature of the bone. I think the results of fixation are very poor. Okay. So it makes more sense to provide early ambulation with a hemiarthroplasty. Okay, so now this age is something which is debatable. I think the physiological age is probably more important than the chronological age. Okay,
so for exam purpose.
Yeah, so I think book-wise it would be 65.
Yes, sir.
But you also look at comorbidities. So if it's a diabetic with multiple comorbidities, osteoporosis, maybe even a 55 qualifies for a hemiarthroplasty. Okay.
Okay. Okay.
So the physiological age. So you can say that in the exams that yes, this is the guideline, but the physiological age is more important than the chronological age.
Okay.
During primary fixation, sir, how many attempts of closed reduction so we can before going for open
You
reduction?
tell me.
Sir, usually you use twice after 2 attempts.
Yeah, so that's what's recommended is to 1 or 2 attempts and nothing very vigorous. Okay, and I think today it's more important to if you're not happy with your closed reduction, to do an open reduction. Okay, and open reduction would depend on where the fracture is. So if it is more basal, then Watson-Jones approach works well because you can do both your fixation and your reduction through the same approach. If it is a really subcapital fracture, then it's difficult to approach the fracture through the Watson-Jones. So Smith-Peterson approach to the reduction, but then you have to make a separate incision for your fixation. So you'll have to do some kind of provisional reduction, K-wires, etc., and then go to the lateral incision to fix it. Okay.
Yes, sir. And what about that fibular graft for the primary fixation? Do it has any role during primary fixation?
Yeah, I think you have to there's no absolute answer to this. If you find a situation where there's a lot of comminution, okay, in a patient you don't want to be doing an arthroplasty on, then you may have so a lot of posterior comminution, a fibular graft may help. But I think again, very little evidence. This is more anecdotal than anything else. Okay, so I don't think anyone's done enough studies to really compare them with or without a fibular graft, etc.
Sir, in revision cases, I have seen few X-rays in the journal. They have given one medial buttress plate. So if combination is more.
No, that's not in revision fixation. That's even in primary fixation. That's one of the things people are using to prevent collapse, is to use a medial plate along the neck to prevent varus collapse. Okay. So the Americans are quite pushy about this, but the problem is if it's a real basal neck fracture, it's really difficult to get the plate into a position where it will actually buttress the fracture. So for the more basal neck, it's probably a good idea, but for the subcapital fractures, which are almost in the joint, it becomes really difficult to get that plate positioned adequately.
Okay, sir. And for the younger patient, sir, is it the reduction should be anatomical or slightly valgus? That one also?
No, you're aiming for anatomical reduction, okay? Now, you might accept a little bit of valgus, but certainly not varus, okay? But your aim is anatomical reduction. Okay? You don't aim for valgus reduction. Yeah? So doing a valgus osteotomy is different from a valgus reduction, okay? If you get a valgus reduction, you increase the risk of AVM. Okay, so I think don't confuse a valgus reduction and a valgus osteotomy.
Sometimes, sir, for the femur shaft, sometimes we find a neck of femur during the OT, during the CM when we are positioning at that time. So to avoid that, what we can do before?
So I think ipsilateral neck shaft fractures are a common problem. Okay. You need to anticipate it, have a high index of suspicion, make sure that you get the hip x-rayed properly. If you look at the recommendations from various authors, they have recommended different things, including a CT scan pre-op. Paul Tonetta, in his sort of recommendations, suggests a CT. But I think what is most important is that you are looking out for it, you warn the patient about it, and today's implants allow you to fix the neck along with, because usually if it's something that you missed, it's not a displaced severe fracture, okay? So you may not have seen it in the original X-ray, but you see it once you put the patient on. The thing is, even in spite of that, some of them get missed, okay? So I think you have to make an effort to make sure there isn't a fracture that you've missed. And that is probably more important than anything else. Okay. So on the table, make sure that you check the neck. The ideal thing, what in that recommendation is to also get X-rays before you reverse the anesthesia and the patient. Not just CM images, but proper X-rays before you reverse the patient, where it's practical.
And so for neck, when you are reducing it up, means after failure of close reduction, when open reduction is required, which approach is appropriate to do that?
I just told you earlier, depends on where the fracture is. If it is a little more basal, then a Watson-Jones works well. If it is absolute subcapital, then a Smith-Peterson approach is what we do. Okay.
Good evening, sir.
Good evening.
Sir, Sir Sumit here.
Tell me.
Sir, is it possible to revise valgus osteotomy with angled bed plate patient who has developed avian after surgery?
So you want to do an osteotomy and a blade plate fixation for a patient who's got AVN.
No, no, sir. The patient was having non-union of neck of femur fracture, for which angle blade plate and valgus osteotomy was done.
Has been done, okay. And
then
he's got AVN, but AVN with collapse, without collapse. So has the head collapsed?
Yes, sir. If head collapses, then what to do, sir? In that case.
So then you have to do an arthroplasty most likely, okay? So if he's very young, then you have some options like the pelvic support, etc. But if the hip joint is damaged, there's AVN and there's secondary osteoarthritis, then you have to, the best option would be a total hip replacement. You can do a total hip replacement with a valgus osteotomy. It's not a problem. So we've done quite a few, okay? Makes your initial entry into the canal a little difficult, but if you're careful, you can do that. Yeah? And if the osteotomy is a lot, then you can do a trochanteric osteotomy and do it. So that's the other option. Huh? But usually you don't need to. Yeah? Because usually the osteotomies are 30 degrees or 35 degrees. It's usually possible to do it. So certainly you can revise it with a total hip replacement. In a very young patient where you want to avoid total hip replacement, you have the options like a pelvic support osteotomy with lengthening. Okay. Doing a THR after that becomes quite difficult. Okay. But with the valgus, regular valgus osteotomy, it's not such a big problem. Okay. So Jaswinder, you're there. Any comments?
Sir, actually, I just joined in. I'm sorry. I got disconnected in between.
Okay. Sir, one question which is slightly different, sir. Because of bisphosphonates, some fractures are there that is difficult to heal. So to treat those fractures, what is different during managing those fractures?
So atypical fractures are a completely different lecture, okay?
It is asked during the...
I know, so it's not, so the issue is to, most important thing in these, so these are usually subtrochanteric fractures, okay? They are not neck fractures, firstly, huh? They're usually subtrochanteric fractures. They have a classical pattern, usually with some prodromal symptoms before the actual fracture happens. Okay, and the first thing is to anticipate it before it happens and do a prophylactic, either stop the bisphosphonates, convert them to something like parathyroid analogs. But if they get symptomatic and you're seeing these, what we call the dreaded black line or signs of an impending fracture, some people would go as far as putting a prophylactic nail in. Okay? That would prevent the fracture from happening. Once the fracture occurs, I think it's important to get the fracture fixation absolutely right. Okay? So these fractures are difficult to heal. They take more time, and even if the fracture is fixed a little bit suboptimally, that means 5 degrees of varus or something, which in a other patient you might accept, the chances of failure become quite high. Okay, so the idea is that you make sure that you get that right. And sometimes you may have to do an open reduction to get the reduction perfectly right. Combine a plate with a nail. So you nail it, but also because they're always in that area where the medullary canal may change from a wide to a slightly narrow position in the isthmic portion. So sometimes adding a plate and compressing on the lateral cortex may be useful. Okay, so it's not a one answer. I think you have to get everything right in the fixation and then stop the bisphosphonates. I think generally teriparatide is recommended for these patients once they've got this fracture. Obviously check their vitamin D, calcium levels, etc. and supplement those as well.
And you have told me regarding the Merrill's criteria while for the prophylactic fixation, sir. Then I have shown you.
Yeah. So that's a criteria for that. Yeah.
And one more question regarding the infected non-union. With after the fixation, if it is get infected, what is your approach for dealing with it?
Of a neck femur.
Yes, sir.
Okay, so I think the approach is the same. First is to diagnose it. Okay, then remove implants, get cultures from different levels, then decide if the hip joint is also involved in the infection or not. If the hip joint is also involved, then you have to look at whether the head is salvageable or not. Okay. And then plan your revision once you've got the infection controlled. Okay. So there again, you may have to do an osteotomy or something. Or if the joint is already involved, then you are sort of going down the salvage path or a arthroplasty path.
And one thing, sir, regarding the pattern of failure, is it depends on the implants what you have used during the primary fixation, or
pattern of failure?
Yes, like
I think the failure. The first and most important thing is the reduction. Okay, I think that's where most things go wrong. Okay, accepting a suboptimal reduction. Okay, and if your head is even a little bit off, once you've reduced it, your contact area actually reduces significantly, and you can't make that out on CM images. Okay, so even a sort of 2 or 3 millimeter displacement in one direction will actually reduce the surface area of contact significantly. And once you've not got adequate surface area contact, any fixation you use are going to fail. Okay, next is your stability of your fixation. Okay. Now, we discussed that we really don't have the ideal implant as yet. There are some new implants which hopefully will have better results. There's the FNS system from the AO. There's the Targon system from another company. There is, you also have this concept of BDSF is the bidirectional stable fixation concept, where you put them in different angles. So I think there are different options, which we still need some time to know what is the best option. But as I mentioned, this is a fracture which is going to continue troubling us for many years.
And sir, do you consider the shortening of the neck, united neck, is a failure, or is it okay, sir?
I think we just discussed that. Now that's the problem with the cannulated screws, parallel cannulated screws. Yeah. Okay, you might get healing, but sometimes the shortening is so much that today patients are not happy with it. Yeah. So that now is the biggest problem with fracture neck femur, is shortening more than even AVN and non-union.
So sir, during the Viva, we can consider it as a failure.
During the Viva?
Yes, sir. During the DNB Viva, when they tell what is the failure, like cutout or varus infection. So that's
so say excessive shortening. Don't say shortening. Say excessive shortening, because otherwise the examiner will tell you that, a little bit of shortening is necessary for fracture to heal. Okay.
Okay.
So remember, so so some of the examiners may not be always totally up to date with the present trend. Okay. So shortening used to be considered as part of healing in trochanteric fractures, even in neck fractures. Okay. So excessive shortening is a complication. If it's half a centimeter, it probably doesn't matter. Okay. So you can certainly say excessive shortening is a complication or a problem.
Sir, one small question regarding that. During the osteotomy, the Powell angle, what you measure, is it same as everywhere else, like 1 centimeter for 10 degree? Or
No, that is so. I mean,
that is
so asking that question is like if you understand how angles work, you won't be asking that question, okay?
Yes.
Because it would depend on the width of that bone as to how much the width would have to be for that angle to be 10 degrees. So if it's a broader bone, okay, that 1 centimeter will be a smaller angle. If it's a thin bone or a narrow bone, even 1 centimeter may be more than 10 degrees. Okay. So I think it varies with the dimension of the bone, and that is why you have to do your osteotomy with the angles, not just looking at the dimension of the cut. Okay. Okay. Of course, if you plan it and then you get a certain sort of number that you need to make your wedge, then that's fine. Okay. But it's not just every case 1 degree will 10 degrees will be 1 centimeter. That is not fact in life. Even in the proximal tibia for the HTO, it was based on the tibia average width, but it varies so much from one patient to another. Okay.
And while doing this one, sir, DHS, when we are putting the guide wire inside, sometimes we used to fix it. So is it wise to go till acetabulum and fix it in the acetabulum, sir? Because few of the devices what you have shown, like that one, TFN, in which we used to put the cement also. So they do not tell to make
So
a
obviously,
hole.
if you're planning to put cement, you don't want to make holes in the joint. Huh?
Okay, sir. So while fixing that one, sir, so it should not come out. We should put it in the acetabulum. That is okay, sir. Or
Yeah, so it depends. Nah? I mean, there's no fixed rules. Okay, I think just putting it in the acetabulum is not going to cause a problem as long as you withdraw it before you do any osteotomy, etc. Huh? Because sometimes otherwise the guide wire just comes out with your reading. Huh? Okay, and then you're struggling to find the right direction again. So I think you can put it into the acetabulum, but then you have to watch it very carefully that it's not going in more when you're reaming. Okay.
yes, sir.
You understand? Sometimes you'll find the guide wire has gone into the pelvis and can even damage the bladder. So you have to be very careful with that. Okay, so you don't want to put it in the acetabulum, but sometimes because the bone is soft and with your reaming the guide wire tends to come out, it may make sense to just tap it into the acetabulum slightly. Yeah? That just one hole in the acetabulum is not going to cause you a problem.
And, one more viva question, what they used to ask for the younger patient when choosing the implant for arthroplasty, which type of head or acetabulum is better?
So I think today, in terms of bearing surfaces, there is reasonable agreement. Okay, so if you have a ceramic head on a highly cross-linked polyethylene, that is probably a good combination. Some people will say ceramic on ceramic, but then that has certain problems related to squeak, etc. Although much less with the newer ceramics, it's still there. In terms of cemented or uncemented, that's a huge debate. Okay, I think you have to figure out what works for you, okay? Because if you look at the registries, there's really very little difference in terms of to say that one is better than the other, okay? Depending on what you look at, you can get good results with cemented or uncemented, depending on which type of uncemented you're using, the results are different. So I think it depends on the surgeon who's doing it. So I think very difficult to come out with a clear-cut answer that cement is better for older patients and uncemented is good for younger patients, okay? Because one of the arguments was revision. Now, revision is actually today with cement and cement fixation is easier with the cemented, highly polished stems than is with an uncemented stem. Okay, so I think this is like a huge debate which will keep going on.
And sir, you told about the anatomical reduction. What is there other things to consider so that the failure rate is less?
I told you, I talked about fixation.
Yes, sir.
It has
Fixation
to be
and
a good stable fixation. Ideally, today we talk about angular stability. Okay. So these are the three basic things. Once you get your reduction right, then your fixation should be stable to allow you early mobilization. Especially, I mean, I think we get the patients up even with the neck femur fractures, at least partial weight bearing.
Okay, sir. So I think almost most of the question has answered, sir. So if anybody else
Yeah,
has,
it's already 10 minutes over time as well. Okay.
yes.
So, okay. Thank you. I think then discuss about the next talk by Swinda or whatever, whenever fix up a date for it. Okay. There's some other people who've shown some interest in giving talks, so we can contact them as well. So,
Yes, sir.
okay.
Yes, sir.
Okay. Thank you very much and bye everybody.
Thank you, sir. Good evening.